even now, I still feel that I'm not completely sure how we determine who should be put forward for IDD therapy. So should we start with that? What is it good for?
Well, I mean, in essence, it's the main thing you're using it for is discogenic pathology, let's just say that. So that could be discogenic back pain, or the obvious one could be disc protrusion, disc sort of slip disc, you want to call it in layman's terms, that's causing a nerve root compression, therefore causing sciatic type pain, or femoral distribution or sciatic distribution. But they're the two main reasons.
Okay, but there are other things which I think if you look through the list of things that Stephen Small, the sort of the main salesman for this kit in the UK, says. I mean, there are other things that you can regard as being potentially beneficial.
Yes, so you might talk about things like facet joint pain, but that would then be potentially secondary to the spondylotic pain. So if the disc is shrunken, you're getting more facet loading, and then that could be the tissue causing symptoms, but it's also coming due to the fact that the disc is affected. My argument would be that it's ultimately the disc that is the unique thing that you're targeting in a unique way with IDD therapy. Yeah.
Now, I've called it disc decompression, the non-surgical disc decompression therapy, which is not what IDD stands for, clearly, but I just think it's a simpler to understand abbreviation. Is that fair?
I think that's very fair. Yeah.
Is there any evidence that it does decompress a disc?
Well, it depends what you might mean by decompress. There's certainly evidence to show that cadaver studies to show that you can get a negative pressure within the disc when you're distracting it, which will then have certain sequences of reactions within the body. Some of it physiological. I suppose the underlying bit to your question is, can you actually change the morphology of the disc? Can you actually make a difference between a bulging disc and then sort of retracting it? And I think that's where there's a lot of nuance and a lot of argument. But it'll come down to a variety of things. So if you've got when we talk about on the MRI course, you often talk about wet disc, dry disc. So a wet disc would be something like along the lines of the nucleus is kind of extruded out to the outer side of the annulus. So that type of scenario is much more amenable to change than let's say a hard fibrosed osteopathic type of disc, which is probably not going to change very much. But it's not all about the morphological change. It's really ultimately it's the symptom the symptomology you're trying to improve, and therefore the physiology behind that. So it's what that disc is doing to the surrounding environment and to the nerve and the other tissues that you're trying to change.